So we're going to talk really quickly about just some basic isolate function and some take-home messages, regardless of the model that you have. This one's going to be a side-by-side. Some people will have stacked units. There's different places to put all your things. This current setup has 2 conventional ventilators and then 1 high frequency with air knocks that can be interchanged with cooling units. But just in general, some good take-home messages is always keep it plugged in. So find your place, plug it in. Don't forget about that because this battery can die. Keep it on as well. When you're keeping it stored, make sure it's in the on position because it doesn't have to work as hard to keep your temperature where you want it. So set your temperature where you like it and just keep it plugged in. And then when you're going between ambulance and bedside, always make sure to go plug it into your nearest power source. Same principle goes with your air and your oxygen. Yes, you might have backup tanks, but just always pretend like you're about to run out of gas. Because if you keep that in mind, you're always going to be in the safest possible position if something bad does happen. So make sure to plug into your ambulance, your helicopter, your fixed wing when you can, and make sure to plug it into your wall at bedside, either at the transferring or receiving facility. That way you're always managing your resources as best you can. Okay, we're going to talk really briefly about our conventional circuit here. You can attach them to several ventilators. In this case, we're going to be talking about the MVP10. Really quickly, as far as different pieces, you got your pressure line right here that's going to be connecting right up to where your circuit Y is going to be. You got your expiratory valve or your PEEP sensor right here. It's going to be attaching to your expiratory valve. Also is going to connect in the back as well. And then it's going to have your main connection for your patient's source gas. As far as understanding about what these things actually do, just think about this as like your proximal flow sensor, even though you don't have one in place with this circuit. That's not what the MVP10 utilizes. It's just going to measure the pressure right there at the ET tube. And think about this one right here as your flow restriction on your ambu bag, if you have those green anesthesia bags, or if you're thinking about a TP's resuscitator when you're restricting exhalation to increase or decrease your PEEP. That's what this piece works right here too. So it'll help limit your pressure and sets your back pressure, and this one right here actually just monitors your pressure. Okay. Let's talk about the patient circuit setup in the back. So you're going to have 3 options. This one's pretty obvious, right? It's going to go right there. This is where your gas is going to be supplied. These 2 can be switched interchangeably by accident if you're not paying close enough attention, and it's going to give you all sorts of crazy readings on your manometer that will eventually clue you off to the fact that you've flipped these backwards. But just calmly, patiently look at what you're doing right here. Take a moment to make sure you're plugging the right place at the right spot. Your expiratory valve right here is going to be labeled expiratory valve. And there's different setups for different units. Sometimes they'll have different pieces right here on your isolate that are going to be coming up here labeled essentially the same thing. This model has some stuff down here that's labeled essentially the same thing for a crossfin. Just take a moment to visualize where you're plugging it in and don't just assume you're in the right spot. So your expiratory valve, and it's always going to be a little bit of a squeeze to get in there. Alright. Patient gauge. This is the one that's going to be going right up here to reconnect your ET tube. Okay. Sometimes they say patient, sometimes they just say gauge. It just depends on the brand and the setup that you have and how it's labeled. So there we go, and just make sure it's fitted on there really well. There are times where if the circuit gets yanked a little bit, or if it's not quite seated appropriately, it'll pop off. And that's not something you really want to troubleshoot while you're ventilating a patient on transport. Okay, we're going to talk briefly just about some of the knobs in your manometer for your MVP10. Just go over some of the basic settings and a few take-home messages. This MVP10 is set up with a blender. It's external and everything kind of comes back in here and blends from the back. You see the 2 flow meters. That exists from a time where blenders weren't as used as much as they are now. So you might find some of them saying warning mixed gas, or some might say air oxygen. But just remember, when you have it set up through a blender, all you need is just one flow meter to start putting some flow into the circuit. There have been times in the past where you had to use X amount of oxygen, X amount of air to get a certain amount of FiO2. But now that we have blenders, we just need to use one flow meter to get enough flow to create your settings. All right. So that being said, let's kind of go through our knobs here. We have one toggle says CMV and CPAP. This one will essentially flip it between your spontaneous mode, which is CPAP, and then something where you need to be more, we're actually breathing for the patient for CMV. So flipping this back and forth, you're going to be giving yourself a rate, or you're going to be giving yourself just CPAP. The first thing you need to do before you even pick your mode is give yourself some flow. This is where I find a lot of people might overdo it. So there's no real good, I can't tell you anything right now about how much flow each patient's going to need. You're going to have to assess the patient to see if are you getting good air movement. Does the patient look air hungry? Are you maintaining the settings that you want? Are you getting good chest excursion? So you need to increase and decrease your flow accordingly to make sure the patient is receiving your settings appropriately, whether it's invasive or non-invasive. So first off, let's just talk about our CPAP. So we're in our CPAP mode, continuous positive airway pressure. See, I gave us a flow of, let's say, 6 right here. You don't have to use both flow meters. Like, for example, if that's a 6 right there and you want to do 6, I mean, you could do 3 and 3, right? But there's really no point for that because we're blending everything. So right now we're on 21% oxygen, flow 6. So right now our PEEP is reading 10. What we want to do, say we want to bring that down to 5 or 6 or 4, wherever you want to put it. But how I adjusted that with that PEEP knob is through essentially this part of the circuit, right? So you have exhalation taking place out here, and if I turn this knob, I'm going to be restricting exhalations. If I increase it, so I'm going to bring my PEEP up. If I decrease it, I'm going to let more gas and bring my PEEP down. And this is what I mean by it's used essentially like that expiratory valve on your anesthesia bags or your T-piece resuscitators. It's essentially functioning the same way, just right there with a little balloon that increases and decreases and restricts exhalation or releases it depending on what you want your settings to be. Okay. So we're going to talk about your CMV, how it's labeled here, your rate, IMV. This is not SIMV, so synchronized intermittent mandatory ventilation. This is more like intermittent mandatory ventilation. There's no way to synchronize with this ventilator, so it's just going to be giving the breath at a certain inspiratory time, giving yourself a certain expiratory time, giving yourself a total rate over a minute. So when you flip it over to CMV, to control your rate, you have to set an inspiratory time and an expiratory time. There's no respiratory rate knob, there's no button to tell you what it's going to be. So you need to decide, based on your patient, what you want your inspiratory time to be. Once you've decided that, then you can adjust your expiratory time to get your desired rate. So just as an example, before we do any math, we're just going to listen to it and hear the changes. So let's say we want our I time to be 0.4 seconds. You can hear your rate right now. Well, if you want to have a higher respiratory rate in a minute, you need to spend less time in the expiratory phase. So if we decrease my E time, our respiratory rate is going to go up. But the I time staying fixed. If we want to decrease our respiratory rate, we want to increase our time in the expiratory phase. So we want to wait a little bit longer between each breath. The simplest way of doing things, you want to do no math whatsoever, is just to count your respiratory rate over a minute. Set your I time, set your E time to whatever you feel like is going to be essentially the correct rate if you don't want to do any math, and just count it. We'll talk about some math here in a little bit, but fundamentally, you can just count it over a minute, and if it's 5 off one way or the other, you would decrease it or increase it accordingly to get to the precise respiratory rate that you want. Now, I'm going to leave it here just for example. example purposes, we're going to talk about our PIP. For our PIP, it's this knob right down here. Let's see that okay. This right here, it does not, don't confuse it with actually creating the PIP. What it does is it limits. So if I increase my PIP, you see how I'm not really going much higher on my PIP on my manometer, and even though I'm turning it and turning it and turning it, I'm still right about a 40, because my limit is somewhere probably up here. I haven't reached it. Now, if I decrease my PIP, so I'm tightening up my limit to where I'm going to trim off part of this breath. Hear that? So now I'm at about, what, 24 or so? And you hear that screeching sound? That's because the flow is pushing against this expiratory valve right here. So one way to get rid of that screeching, right, is to decrease your flow. So that might be an indication that your flow might be a little too high for the settings you're trying to get. So listen to breath sounds, look at your chest rise, put an end-tidal CO2 monitor in there, see what your end-tidal CO2 is, see if you're getting good reading there, that's where you want it. Increase and decrease your rate accordingly with your expiratory time, and you want to either trim off your high end right here, your PIP, to create your settings, or if you increase it, you're allowing it to go a little bit higher. One other way to control the PIP is to increase or decrease your flow. And you know this naturally by dealing with your anesthesia bags, right? If you don't have enough flow, you can't get the desired settings. So as I decrease my flow, I'm not able to attain my appropriate size PIP. But it's good to notice that, hey, this is a flow of 3, and I'm still getting about a PIP of 20, right? So this is where people sometimes put in too much flow, do a 6, trim it down too much, and you get essentially the same setting and blowing off significantly more CO2 with increased flow. So there's a balance between flow and limiting your pressure that you should be aware of to not overventilate them. One of the times you see this happen the most is when you go and pick up a patient who's already ventilated on some settings with a good blood gas, and you want to mimic those settings. And if it's an Avia or a Servo I or Pearson Bennett, any one of the normal smart ventilators you'll encounter in a nursery, you could essentially have the exact same settings with the same rate, but with significantly more flow, and get yourself a unexpected decrease in your CO2. You could be over-ventilating even though all your numbers are the same. It's also really good to look at your ventilator before you put them on MVP10 and see what type of flows it's taking to create those settings. And that might give you a little bit idea where to start. Not to say that it's going to be perfect, but it'll give you a little bit of idea.